Hello students, today we will look into the dietary management of three major renal diseases: uremia, renal dialysis and the renal transplant. Before that, let us have a look into the brief functions of kidneys. Kidneys are bean-shaped structures, each about the size of a fist and weigh about 150 grams in males and 135 grams in female. They are typically 10 to 12 centimeters in length, 5 to 7 centimeters in width and 2 to 3 centimeters in thickness. Each kidney contains around 1 million units called nephrons, each of which is a microscopic filter for the blood. It's possible to lose as much as 90% of kidney function without experiencing any symptoms or problems. The major functions of kidneys are formation of urine, maintaining fluid and electrolyte balance, acid-base balance, regulation of blood pressure, filtration and excretion of waste products, secretion of certain hormones, metabolic functions like gluconeogenesis, detoxification of drugs, hormones, etc. Now let us look into uremia. Uremia is a clinical syndrome consisting of a variety of symptoms and metabolic disorders due to the progressive, irreversible decline of the kidney function. The end stage of chronic renal failure is uremia. Uremia is not an independent kidney disease but a series of clinical manifestations, and it is the common syndrome of nearly all the kidney diseases in their end stages. In the end stage of uremia, nearly all the systems will be involved. Uremia, also known as uremic syndrome, is a serious complication of chronic kidney disease and acute kidney injury, also known as acute renal failure. It occurs when urea and other waste products build up in the body because the kidneys are unable to eliminate them. These substances can become toxic to the body if they reach high levels. Prolonged or the severe fluid buildup, that is edema, can make the uremic syndrome worse. Uremia is a clinical syndrome associated with fluid, electrolyte and the hormone imbalance along with metabolic abnormalities. They develop in parallel with deterioration of the renal function. The term uremia literally means urine in the blood, that is, the presence of the waste nitrogenous products in the blood. In the presence of renal failure, then, these functions are not performed adequately and there are metabolic abnormalities such as anemia, acidemia, hyperkalemia, hyperparathyroidism, malnutrition and also hypertension. The typical symptoms that are associated with uremia are symptoms in the GIT. These are the first and the most obvious symptoms like loss of appetite, discomfort in the abdomen and then nausea, vomiting, diarrhea, glossitis, oral ulcers and a urine taste in the breath. Symptoms in the nerve system include headache, dizziness, there is a trance, apathy, lethargy, drowsiness and sometimes even coma. In the end stage, there will be irritability, muscle trembling, seizures and convulsions. Symptoms in the cardiovascular system include hypertension, arrhythmias, which are the most common, and in the end stage, there is fibrinous pericarditis and heart failure. Symptoms in the hemopoietic system include serious anemia, tendency of bleeding, and symptoms in the respiratory system include deep and long breath in the case of acidosis. Patient can suffer from uremic bronchitis, pneumonia and even pleurisy. Symptoms in the skin, that is, there will be uremic frost in the skin due to the secretion of urea from the sweat glands, and the uremic frost will irritate the skin causing itching. There is metabolic acidosis and acid-base imbalance. And the other common symptoms include loss of appetite, insensitivity, lethargy, decreased urine output, edema in the face and the lower extremities, anemia, skin ulcers, muscle cramps and sometimes even epilepsy. Malnutrition therefore usually occurs as the renal failure progresses, and this is manifested by weight loss, which could be because of anorexia. There is loss of muscle mass, the cholesterol levels are low, the BUN levels, that is the blood urea nitrogen levels in the setting of an elevated creatinine levels are seen, serum transferrin levels are low, and there is hypoalbuminemia. If we look into the etiology or the causes, the most important is primary glomerular and the tubular disorders. There can be IgA nephropathy, polycystic kidney disease, lupus, amyloidosis, Goodpasture disease, and it can be also be due to multiple etiologies, but it is associated with uremia when there is a rapid rise in urea or creatinine occurs. However, one must remember that diabetes is the most important primary cause of ESRD. The treatment, if we look into it, the ultimate treatment for uremia is always dialysis. Dialysis has to be initiated when the signs or symptoms of uremia, that is nausea, vomiting, volume overload, hyperkalemia, or even severe acidosis are present, and they cannot be treated by other medical means. Dialysis must be initiated as soon as symptoms are present, regardless of the GFR, that is the glomerular filtration rate. If we look into dialysis, for asymptomatic patients, dialysis generally initiated when the creatinine clearance rate is 10 ml per minute or less. For diabetic patients, when the rate is 15 ml per minute, that is when the creatinine level is 6 milligrams per dl. Early referral to a nephrologist for evaluation is essential for patient education and also preparing the patient for dialysis or transplantation. There are two types of dialysis, hemodialysis and peritoneal dialysis. Let us first look at hemodialysis. A dialysis machine filters waste and excess fluids from the blood through a man-made membrane called a dialyzer or the artificial kidney, which cleans out toxins, and the kidneys can no longer remove these toxins. The filtered blood is then returned to the body. The average person has about 5 liters of blood. During dialysis, only about half liter is outside the body at a time. Hemodialysis is generally performed 3 times a week, and it takes about 3 to 5 hours per treatment session. In peritoneal dialysis, a cleansing fluid, that is the dialysate, is circulated through a tube, what is known as a catheter, inside the abdominal cavity, that is the peritoneal cavity, and hence the name peritoneal dialysis. About 2 to 3 liters of dialysis fluid is infused into the abdominal cavity through the access catheter. The fluid is allowed to dwell for 2 to several hours before being drained, taking the unwanted waste and water along with it. The fluid typically needs to be exchanged 4 times a day. The dialysate absorbs waste products from blood vessels in the abdominal lining and then is drawn back out of the body and discarded. This is just a pictorial representation to show how the peritoneal dialysis is done. We have a bag which contains the dialysate solution, from where the fluid is entered, cleaned, and the waste is drained out through the drain line. So, the goal of treatment in dialysis patient is to control complications such as hypertension, bone pain, and control nervous system abnormalities, to retard progression of renal failure, to control fluid and the electrolyte losses from vomiting and diarrhea, to carefully correct the metabolic acidosis, to avoid dehydration or overhydration, and to maintain optimal nutritional status. The diet will have severe restrictions and adherence to it can be very difficult. Diets have to be individualized not only to meet the nutrient requirements but should also be acceptable in terms of palatability, cost, taking into account the comorbid medical conditions, cultural eating habits, etc. Too many restrictions should also be avoided as it can lead to poor food intake. Other major concerns in the adequacy of dialysis: less than adequate can adversely affect appetite and thereby the nutrient intake. If we look into the requirements for energy, patients below 60 years of age are recommended to have 35 calories per kg per day, and for patients above 60 years, 30 to 35 calories per kg per day. However, it is difficult to achieve the recommended intake. In both types of dialysis, a substantial amount of glucose from the dialysate is absorbed, and this is equivalent to roughly 300 to 400 calories. So, the energy from carbohydrates need to be adjusted keeping in account these 300 to 400 calories. Proteins, roughly 1.2 grams per kg per day is recommended. 50% of these should be from high biological value, that is proteins from animal sources. In peritoneal dialysis, 1.5 grams per kg per day is recommended as 10 to 20 grams of protein is lost into the dialysate. Lipids, roughly 25 to 35% of the total calories can be from lipids. The goal is to achieve LDL level below 100 milligrams per dl, and the fasting triglyceride levels should be less than 500 milligrams per dl. For the carbohydrate requirement, 50 to 60% of the total calories in hemodialysis should be from carbohydrates, and in peritoneal dialysis, 40 to 50% of the total calories should be from carbohydrates. 20 to 30% gram fiber per day is recommended, and this helps in reducing dyslipidemia. Sodium intake in hemodialysis, 1 to 1.5 grams per day is recommended, while in peritoneal dialysis 3 to 5 grams per day can be consumed. For potassium, in hemodialysis patients 2 grams per day is recommended, and in peritoneal dialysis 3 to 4 grams per day is recommended. Generally, calcium is about 2 grams per day. Phosphorus, 3.5 to 5.5 milligrams per dl should be the target. Higher levels are associated with the cardiovascular events. The next component of the class is renal transplant. Kidney transplant is often the best treatment for kidney failure. It is generally indicated for end-stage renal disease, ESRD as it is generally known. It is a surgical procedure that involves the transplant of a kidney from the donor to a sufferer of ESRD, also known as the recipient. There are different types of donors. One is the deceased donor. The person who is expired can donate his kidneys to a kidney transplant patient. Living related donors tend to be better matches because of the blood and the antigen compatibility, and there is a less chance for the rejection of the kidney. Or it can be a living unrelated donor. One thing we have to remember that rejection and infection are the major complications after renal transplant. To allow the transplanted kidney to survive in a new body, immunosuppressive drugs are given for the rest of the life to fight rejection, and this is something we must remember. The transplant surgery is performed under general anesthesia. The surgery usually takes 2 to 4 hours. During the operation, the kidney is placed in the pelvis and not at the usual kidney location in the back. The original kidneys are not usually removed unless they are causing severe problems such as uncontrollable high blood pressure, frequent kidney infections, or if the kidneys are getting enlarged. The artery that carries blood to the kidney and the vein that carries blood away from it are surgically connected to the artery and vein already existing in the pelvis of the recipient. The ureter or the tube that carries urine from the kidney is connected to the bladder. This is a pictorial representation for you to have a look at how the transplanted kidney is placed in the pelvic region, and the diseased kidneys are retained and not removed unless there is some problem. Goals of the treatment for transplant patient is to promote normal blood pressure, maximize bone density, to retard the progression of renal failure, to control fluid and electrolyte losses, to carefully correct metabolic acidosis, to avoid both dehydration and overhydration, to control blood glucose levels, to maintain optimal nutritional status. The major concerns in renal transplantation are hyperlipidemia. This is associated with use of drugs like glucocorticoids and cyclosporine. These in turn can be responsible for cardiovascular disorders. Elevated levels of homocysteine is also commonly observed, and hyperhomocystinuria is an increased risk factor for CVD. Supplementation of folic acid, pyridoxine or B6 and B12 is therefore recommended in transplant patients. Bone health also has to be maintained. Bone loss occurs in the first 6 months post-transplant. Adequate calcium, phosphorus and vitamin D have to be provided. Obesity and weight gain is also observed in transplant patients. This could be due to hyperphagia and that increased sense of well-being among these transplant patients. Managing the calorie intake and an exercise regime is essential. In the acute post-transplant nutrition management, which is generally 4 to 6 weeks period after surgery, the goals are adequate calorie and protein intake to counteract protein catabolism, promote wound healing, decrease susceptibility to infection, maintain water and electrolyte balance. The dietary recommendations are calorie 30 to 35 calories kg per day, proteins about 1.3 to 2 grams per kg per day, fat 35% of the calories should be fat with the saturated fat less than 7% of the total calories, and the cholesterol levels have to be maintained to less than 200 milligrams per day. Sodium intake is restricted to 2 grams per day. Hyperkalemia is very common, so the potassium intake too has to be restricted. Hypophosphatemia and increased urinary loss due to high PTH levels call for an increased intake. Fluid should be restricted to 2000 ml per day. The nutrition recommendations change for a stable transplant patient. Energy 25 to 30 calories per kg per day, and now the proteins come down to 1 gram per kg per day. Fats, a low fat diet is given. Not more than 30% of the calories should be from fats. Low cholesterol diet is recommended as weight gain and hypercholesterolemia is often observed in post-transplant patients. Cholesterol should not be more than 300 milligrams per day. Carbohydrates should provide about 50% of the calories. Sodium intake is restricted to 2 to 3 grams per day. Potassium, always a problem because hyperkalemia can set in, and that is why it is restricted to less than 2 grams per day. Calcium, phosphorus and vitamin D. Calcium 1000 to 15 milligrams per day is recommended. Phosphorus intake has to be low, about 1200 milligrams per day, but supplements of vitamin D are essential. Similarly, supplements of vitamin C and E are also generally recommended for transplant patients. So, in conclusion, we can say that uremia is a clinical syndrome consisting of a variety of symptoms and metabolic disorders. The end stage of chronic renal failure is uremia. Uremia is not an independent kidney disease, but a series of clinical manifestations, and it is the common syndrome of nearly all the kidney diseases in their end stages. Anemia, hyperkalemia, hyperparathyroidism, acidosis are very often associated with uremia. However, the ultimate treatment is always dialysis. Dialysis can be peritoneal or hemodialysis, which helps in removing the waste from the body. In both the types of dialysis, there is a substantial amount of glucose from the dialysate which is absorbed, and hence the calorie intake has to be adjusted, particularly the calories provided by the carbohydrates. Proteins are generally not restricted, but sodium, potassium and the levels of LDL and triglycerides have to be monitored. Similarly, the cholesterol levels also need to be monitored. In transplant patients, the first 4 to 6 weeks are very critical. There is always a chance of the patient rejecting the kidney. Blood pressure, bone health have to be attended to. Fat, sodium, potassium, phosphorus are the major nutrients which need to be monitored. Thank you.